she will speak about what do we know about global inequalities in adolescent health outcomes. Susan, I'm happy to give the floor to you.
Thanks very much, Hoff, and warm regards to you all. Yeah, moving to the country when I was 12 from Melbourne was a huge shock to the system. And again, that notion of the different cultures of adolescence that I think Danielle might pick up later. But I think as Sir Michael Marmot said, that adolescents have been neglected. They have been disadvantaged. They have least access to mental health services of any age group. And they have greatest use of unsafe abortion. So whether we're talking about mental health or sexual health, just two examples here. And when we ask health professionals, what population group are you most challenged by? Study after study tells us that it's adolescents. I put this data up to also suggest that adolescents are disadvantaged. This is a study from Russell Viner in the UK looking at 50-year mortality trends, all-cause mortality trends. And if you just focus on the top panel, which is looking at male mortality in under 25-year-olds, I've highlighted in purple the dramatically impressive 80% reductions in mortality in 1 to 4-year-olds in comparison to the flatlining of blue in 15 to 19-year-old males, a pattern that's replicated in females. So inequalities across different populations, and obviously in terms of COVID-19, and we're experiencing inequalities in terms of age in a different way. Now, why isn't my screen going? So another question to you in terms of inequalities. In the past 10 years, what proportion of research do you think has been undertaken in under 5-year-olds versus 10 to 19-year-old adolescents? It's only 5 years versus 10 years of adolescence. So is it about 50%, 45% of research, 75, or might it even be as disproportionate as 95%? The actual answer is 95%, or indeed, depending on which search engine you look at, actually 99%. So in terms of in unequal investments in research, certainly adolescents have missed out. Now, the definition of adolescence we used in the Lancet Commission for Adolescent Health that was published in 2016 was this period of time where it was a profound period of human growth and development in which the assets and capabilities that underpin future adult health and wellbeing, social relationships, parenting and employment are established. This is a very different definition to perhaps the definition that I grew up with as a medical student, if I'd been taught anything about adolescence, but I don't actually think I was, this brief period of turmoil to one which we now recognise as a foundation for future health. And in terms of that question from Aaron Deep, in terms of the age definition of adolescence, WHO's current definition is 10 to 19. But certainly in the Lancet Commission, the definition that we used was a much more extensive definition, which is increasingly being used from 10 through to 24 in recognition that so many of those life transitions indeed are extending into the third decade of life. But I've also put up this quote from the front cover, or highlighted it here, about adolescence as this transformative period, both in the life course of us as individuals, but transformative in terms of the health and wealth of nations. Some of you may have heard this notion of the triple dividend, and it's a different way of, in effect, explaining what Sir Michael Marmot started his terrific introduction with in terms of thinking about causes and consequences. I refer to this as the butterfly diagram, and this comes from the Lancet Commission. And if we think of the horizontal line in the body of our butterfly, we can see those, if you like, life course trajectory from preconception through into adolescence, adulthood, and then around into the next generation. And I don't think of as adolescence as the end of childhood, but I actually think of adolescence as the start of the next generation. And if indeed we are wanting the best start to life in the next generation, then investing in adolescence is where it starts. It's too late to think about, if you like, preconception health. But in terms of the wings of our butterfly, they meet ideally such that the actions that are put in place at a national level, at a local level, are matched to the needs in a population, whether those needs relate to health problems, whether they are health risks, or indeed whether they're larger determinants of health. In the Lancet Commission, what we did in terms of thinking about health needs at a country level was that we calculated and summed all of the ICD-9 codes back then, I think it was. So these 9 groups of disorders, and we combined the burden of disease into these 3 broad groupings of diseases of poverty, injuries, including violence, and non-communicable diseases. And then country by country, we grouped countries according to where their excess burden was. And you can appreciate that as we move from left to right here towards non-communicable diseases, we are seeing a different pattern, what is referred to as the epidemiological transition. This is a slightly complicated diagram, but I'm going to take you through it. The reverse pattern is here. So if you like, NCD predominant countries are the 2 panels on the left, females and males, injury excess in the middle, again, females and males, and multi-burden on the right. And this is the change in the burden of disease, so disability adjusted life years using model data from IHME from 1990 through to 2023. And what you can see in multi-burden countries on the far right here is this excess burden from HIV, infectious diseases, sexual and reproductive health, this is particularly maternal mortality, and undernutrition. And you can see that there have been some substantial improvements. In the middle, you can see a disproportionate burden, not from those types of conditions. These countries have managed to get on top of these conditions, but we can see this heavy burden of violence and injury related morbidity and mortality that is particularly pronounced in young men. And then in all countries, we can see this green swathe underneath of chronic physical disorders in dark green and mental disorders in pale green. So straight away, we can see the inequalities here of appreciating that there is double the burden of health, if you like, in multi-burden countries in adolescence versus NCD predominant countries. So a question to ask you, another question, in the past 25 years, has the scale of health problems in adolescence got better or has it got worse? I'm using this data from Peter Azzopardi to demonstrate this. If we look at 1990 in comparison to 2016, we can see that many more countries in 2016 are green or NCD predominant countries with a better disease burden, if you like, than the multi-burden countries. And indeed, back in 1990, only 16% of countries were NCD predominant, and now in 2016, 45% of countries are NCD predominant. So for those of you who answered yes, that the health burden is getting better, you're right. However, for those of you who have said it's getting worse, you are also right. Why might that be? Demography is the answer. If we go back here for a minute, we can see that where the population is greatest in young people is in sub-Saharan Africa and South Asia, the Indian subcontinent. And what we can appreciate then in terms of the growth of those populations of adolescents, that from 1990 through to 2016, there has been a disproportionate growth in the number of adolescents growing up in the world. Indeed, 250 more adolescents growing up in the world, or 35% increase in 2016 to 1990. So in that sense, the number of adolescents growing up in the worst disease pattern has got worse, not better. But as Danielle's going to be highlighting, there are major within-country disparities. And I simply put up this panel again, also led by Peter Azzopardi, looking at differences in Australia, my own country, looking at a dreadful record of the effect on health of dispossession, of colonial trauma, on education, labour force participation, parenthood in young women, whether we're comparing non-Indigenous Australians in blue versus Indigenous Australian adolescents in green. And similarly, we see double the deaths in all ages, 10 to 14, 15 to 19, 20 to poor in Indigenous versus non-Indigenous adolescents. So whether we're talking about LGBTI status, whether we're talking about immigrant populations, whether we're talking about Indigenous populations or low SES, we see a very disproportionate burden. So we might think if we've got disproportionate research and disproportionate burdens, we might have greater investment, what is known as developmental assistance. So my final question here to you is what proportion of developmental assistance goes to adolescents? So developmental assistance is what is supported in countries who are poor and need additional income. Those countries have about 30% of their population being young in the age from 10 to 24. So we might think perhaps proportionately we should be investing 30% of developmental assistance going to adolescents. You might think it's 13% because 13% of the disease burden in these countries has been modelled to be from adolescents. Or is it very low? Is it, say, 2%? Those of you who think it's very low are right. The actual answer is 1.6%. So again, inequities of research investment, inequity in terms of developmental assistance. So what do we need to do to reduce global inequalities in adolescent health? As far as I'm concerned, we need investment here. Investment in adolescent appropriate policies and programs, investment in research so we actually know what they are, and investment in professional education and training, because this is where in the absence of critical mass and in the absence of a change in mindset, we will just keep doing more of the same, that is neglecting adolescents. In terms of that, as president of the International Association for Adolescent Health, I would warmly invite you to join and contribute yourselves to that critical mass, be part of a movement with young people themselves to be aiming to reduce some of those global inequalities. Thank you very much.
Thank you so much, Susan, for